Good morning, and thanks for joining us this morning. My name is Kate Carpenter, Program Manager for the Compass HIN. As we get started, I'd like to acclimate everybody to the webinar platform for today. If you've dialed in using the webinar link, you'll notice in the bottom left-hand corner of your screen, if you haven't already dialed into audio, click the Join Audio button for dial-in instructions. If you're logged into the platform, there's a few functions we'd like to draw your attention to at the bottom of the screen. Furthest to the left, you'll see the chat function, and we'd like to encourage you to find that now. Go ahead and type in the name of your facility, who you are, and what role you're in. We'd love to know who's in the room. Throughout today's presentation, you can use the raise hand function if you've got a question, or submit that question through the Q&A box furthest to the right. Some additional instructions before we get started today. Today's session will be recorded and transcribed, and we'll be providing a link to this recording along with the slide deck to all registered attendees early next week. Recording of this session will also be posted to Hinnovation. And I can see you all beginning to chat in who's joined us today, so thanks for doing that. We appreciate you joining us and are happy that you're here. We have a packed full hour, so without further ado, I'm going to present today's speakers. Joining us again following our recent CANDOR workshop series here in Des Moines to present Are You Ready for CANDOR is Dr. Timothy McDonald. Tim is the president for the Center of Open and Honest Communication at the MedStar Institute for Quality and Safety. He's a professor of law in Chicago and a physician attorney whose research has focused on the principled approach to patient harm with an emphasis on reporting patient safety events, the use of simulation and human factors analysis, and providing open and honest communication following harm events. His federally funded research has focused on these domains and their impact on improving the quality of care while mitigating medical liability and other legal-related issues. Joining Dr. McDonald today is Marty Hatley. He's currently the president of the Partnership for Patient Safety and co-founder of Consumers Advancing Patient Safety, a nonprofit organization dedicated to fostering the role of the consumer as a partner in pursuing healthcare that is safe, compassionate, and just. Drawing on his experience as a civil rights attorney, malpractice defense litigator, lobbyist, and coalition builder, Mr. Hatley is active in both public and organizational efforts. Thank you for joining us today. Tim, I'm going to pass the floor to you.
Thanks, Kate, and thanks for that kind introduction. Again, a reminder to all those attending, feel free to type in any questions that you have as we go along. We'll kind of keep an eye on the chat box and kind of answer them if possible as time goes on. And then we're going to try to leave enough time at the end of this webinar to give people a chance also to send in some of their questions. Marty, super great you've joined me here. He's the voice of the patient and family engagement, and this CANDOR work could not be sort of where it is without your input, Marty. So thanks for joining us today.
Sure, happy to be here, Tim.
Great. So next slide, Kate. So the key thing to keep in mind is that CANDOR is otherwise what we would call a CRP, where CRP stands for a Communication and Resolution Program. And simply put, these are comprehensive, principled, systematic approaches to the prevention and response to harm. This is not the response to medical error. This is not a response to mistakes or negligent care. The key to CANDOR is responding to all significant harm. Where fundamentally the goal of any CRP, but particularly CANDOR in Iowa, is to normalize compassion and honesty. And in fact, that was the real goal of the 4 workshops that we put in. It looks like somebody's not hearing the sound there, Kate, so I'll refer that off to you. That would be great for you to take that. So next slide. When it comes to understanding whether or not the organization is ready for, quote, CANDOR, there are these buckets that are critical to begin to think about your own organization and where you are in these 4 domains. The first is having an early warning system where you're able to identify, very quickly one of these harm events, these significant harm events, where you're then able to activate your system. And we'll talk about that in a minute. Where you're able to respond and communicate very quickly to both patients and families as well as caregivers. This is not necessarily responding with an apology, because you certainly won't know yet. And it certainly isn't necessarily responding quickly with understanding all of what's happened. It's just a matter of responding so that you can maintain trust with patients and families as well as caregivers when these happen. And then simultaneous to that, as you're reviewing these events, as you learn more, you share more. And as you learn more, you share more until ultimately you're able to come to some sort of conclusion as to whether the care was appropriate or not. Either way, you're going to want to resolve these cases with the family, with the data showing that more than 90% of the time, that resolution is just going to be explaining to the family what happened, how the harm occurred, and the fact that, as it turns out, the care was appropriate. Again, that's going to be more than 90% of the time. But occasionally, you're going to have circumstances where it turns out the care is inappropriate. Marty, do you want to speak a little bit about what we've learned from you and patient advocates about this need for the rapid response as it relates to communicating with patients and families?
Well, I think the major insight we've learned is that the early communication is very important. If they don't get it, they feel abandoned. That's a powerful word that has come out of the dialogue. There's a prominent patient activist who came into this work with us early on, and she framed it this way: that every hour that goes by without a communication from trusted doctors or leaders is another harm. So there's the unexpected harm event, and then we compound that by not communicating quickly. I would say the other thing is, if we wait for communication too long, they think, well, we are circling our wagons, and they start circling their wagons. And those are the major insights, Tim, that I think have come from them.
Yeah, thanks, Marty. And the reason we talk about this now, as we get into the "Are you ready?" conversation, it's good in your organizations to begin thinking about, if you had an event happen right now, how well prepared are you to begin a comprehensive and systematic approach that includes communication with the family, in the context of, as you learn more, you share more, and as you learn more, you share more, in a way where it's a coordinated way where the communication is coordinated. Next slide, Kate. So this really represents a significant paradigm shift to the way that a lot of patient safety programs are designed, at least currently. Many of them have made progress in all 5 of these domains, but the goal is to go from reporting that may be sometimes delayed to actually immediate. And when we talk about immediate, one of the things that's important to think about in your needs assessment or gap analysis is it clear to everybody in the organization the one number they can call to get help when there's a harm event? And when I say help, it's help in the big 3, components of what we would call the GO team, or the components that make up a very highly functional CRP, and that is the communication with patient and family, the beginning of the event review, and then the immediate reach out to the caregiver or the members of the care team. And so you can see the paradigm shift. This is shifting away from what I grew up with years ago in our system, where communication to patients and families is immediate and ongoing, moving away from delay, deny, and defend, and event review really focusing with a just culture background, human factors process redesign, and then for the clinicians, making sure that we are providing immediate and ongoing support and not having them suffer in isolation. And finally, for the legal and the claims folks and the other people on here that may get involved at all in the financial piece is when it turns out care's bad, which again is the minority of cases. How do we put that in the queue to hold ourselves accountable consider an early offer and not having the families or the patients fight for it. Next slide. So one of the other ways that we begin to think about this is this notion that how we respond at these plane crashes in the lives of these patients, how we respond really defines who we are as people and as organizations. And next slide. And one of the things that we speak to this as it relates to assessing organizations and their ability to really manage a very coordinated CANDOR process is taking this sense of a serious harm event, quote, go team, not unlike NTSB's plane crash investigation team, where the goal is to get as quickly as possible the expertise there in the big three. Next slide. Where again, the big three includes a sort of state-of-the-art event review team, really well-grounded in just culture, and very fundamentally focused on human factors process redesign, because we know we'll never be able to punish our organizations or our people into high reliability. It's a matter of understanding what happened and redesigning our process. And then that's simultaneously, as we discussed, how do you launch your sort of peer support team, your care for the caregiver team there, and then that patient and family communication team, that consult team that is able to really support the doctors and nurses, provide them advice in a systematic way to begin the conversation sort of related to that. Next slide. So again, one of the things that we did and the work we've been involved with over the years is to make available to any and all hospitals a sort of readiness assessment and gap analysis approach. One area where you can find this online is at ahrq.gov/CANDOR. This was part of what Marty and I, as individual architects of the CANDOR Toolkit, we contributed to, which is this gap analysis approach, where if you go to the website, you can actually see a lot of the teams that we're talking about here, where you're able to, in a systematic way, look at your current processes and outcomes, and then look towards a future state and identify and document sort of the gaps for doing that. So next slide. So I'm going to give you some background on how this sort of gap analysis work came to be. We used this tool back in 2010 through 2012 when we were trying to implement CANDOR in the Chicago area. And one thing we recognized as we failed 80% of the time. And by having done this sort of gap analysis background before going into these hospitals, we were then able to identify where are those risk areas where it may be risky for an organization to proceed with CANDOR implementation, or perhaps the implementation isn't designed in a way to maximize the likelihood of success. Because of what we learned here, we then had the opportunity to help build the CANDOR Toolkit. And that involved working with 14 different hospitals on the East Coast, as well as on the West Coast. And you can see there, part of it was with MedStar Health. And then we also had work at Christiana Care in Delaware, and then the 4 hospitals in Dignity. Important for the people on this webinar is that most of these hospitals were private hospitals with a significant number of independent medical staffs. Unlike the University of Illinois, the University of Michigan's, the Stanfords, and the others, where everybody is under one insurance bucket, except for Georgetown, within MedStar, all of these other hospitals included a significant number of independent physicians. Since then, we've used this in more than 200 hospitals, and you can see the states that we've used these in. And it's been really helpful to identify areas of focus or risk as you consider moving forward with this approach to CANDOR implementation. And it can be used as an ongoing assessment tool as well. So next slide. So when we built when we built this out, this is kind of how the tool is made and how useful it is, and we'll begin to share some of that with you. The first is this need to review important documents. These include recent survey results, your safety culture survey, but also, as you'll see, your policies, policies related to disclosure, policies related to, particularly in Iowa, how are you making sure that you are taking the advantage of the CANDOR legislation in Iowa, which is again, a super important, piece to, for folks to keep in mind. And then we conduct these facilitated focus groups. And I'll share with you a little bit about some of these. These include the C-suite, members of the board, top management, middle management, all the way down to frontline, both clinical and non-clinical people. These facilitated focus groups to get a sense of where is the organization. And then using some of the work that we learned from Chasen and Loeb from the Joint Commission, we also look at the high reliability domains of culture, leadership, and improvement. And through this process, you're able to kind of measure yourself. Where are you in moving from good to great, particularly as it relates to the high reliability domains. And then the questions that you will see that are built into the documents that are available at the AHRQ website, and ones that we have available focus on the National Quality Forum Safe Practices 1, 2, 5, 7, and 8. And those include your process for identifying and mitigating risks and hazards, event reporting, how do you do your RCAs, culture is NQF safe practice number 2, and of course leadership is number 1. And then we look at where is the organization as it relates to open and honest communication with patients and families, as well as what do you have in place for supporting caregivers when things happen. Next slide. So when you look at the high reliability domains, the ones that we focus on, as you can see there, include culture, performance improvement, and leadership. And again, how well and how far are you evolving in the domains of trust and teamwork, accountability, your performance improvement, as well as the leadership component as well. Next slide. And one of the other things I wanted to share with you is the importance of again, looking at the policies. So the report that gets created from this should focus on these facilitated interviews you have with various staff members, identification of common themes, that high reliability assessment we discussed, as well as a SWOT analysis and next steps. Marty, do you want to speak a little bit to these facilitated conversations? Because you've been present at over 15 of these, and you want to share a little bit about the power and the importance of some of those conversations with the staff.
Sure. So the approach that we take is to really try to hit multiple levels of staff. Everything from board members to patient family advisory group members to senior leadership to frontline clinicians to administrative staff. And we create a safe space for them to understand what CANDOR is, and for them to tell us about their experiences. We actually also really engage them in telling us what they would like to see changed in the organization. And what comes out a lot is just the burden and the trauma and the disconnects in an organization. Lots of times we find organizations that are doing a lot of things right, but they're just not connected together. And an example would be, people who get brought into an RCA process, for example, but then never hear the results and wonder what happened, and wonder, if their input made any difference. So we roll that up into a report and take it back to the leadership of the organization to basically show them their readiness for implementation and where the gaps are and how to address them.
Yeah, and thanks for that, Marty. The other thing we do, and again, Marty, if you can comment on this, because it's one of the things we found really valuable. We begin every facilitated session by asking people where they get their greatest joy in their job. And then we finish each of these 50-minute sessions, 5-0, by asking them if they had a magic wand, what would they like to see changed in the organization that would bring them more joy? We learned a lot from that, Marty, didn't we? Don't you think?
Yeah, I mean, just that framing, I mean, that is sort of the way to create the safe space, but also to energize people into realizing that their organization really cares for them. So, we do this in a way where we don't take names and where people are often in these sessions without their supervisor. So they really feel like a safe space. But other examples of things that we hear are somebody who's involved in a really traumatic event. There is a debriefing process, but it doesn't happen for 2 weeks. So, for example, we heard a nurse talk about how she'd walked in on a patient in the process of suicide, and how it was left to her to wrestle with the situation. And it was completely traumatizing, and she just, got a debriefing, but the process in the hospital was just a couple weeks later. Also, Tim, we are hearing a lot, I think recently, especially about civility, behavioral health issues from administrative people who are confronted with patients who are frightening. So there's a lot of stuff that comes out of this that really gives you a sense of the opportunities an organization has to connect the dots.
Oh, you're so right, Marty. One of the other areas that came up along with that is, and I'm sure everybody in this call is aware, because it is, and I know it's a high priority for the folks in Iowa, but it's the whole issue around the opiate epidemic, and how when you get patients who come in who are so physically dependent, and if the organization tries to take a position to really try to limit the opiate use and to convert to alternatives, the incivility that can result from the frustration that all the people feel is a big part of the safety culture in the organization. So it was very interesting to get people to chat about that. So next slide, Kate. So I just want to talk a little bit about this importance of policy review, and we'll move to the next slide as well. This is super important. So here's an example of a policy of an organization, not in Iowa, where this policy, which is the disclosure of unintended outcomes, this is a system of about 5 or 6 hospitals, but this policy applies to all of them. And you can see there that they try to define what an unanticipated outcome is, but when what they say that's so was disturbing to me as a pediatric anesthesiologist is that, when a patient is informed in advance about risk potential, the fact that it occurs no longer renders the outcome anticipated, which is to say there's no need to have one of these open and honest communications with the family, even in the event that, let's say, their child dies following surgery. And if during the informed consent, the risk of death was discussed, per policy, there is no need to have these conversations, independent of whether mistakes were made. And so these are the kind of policies that are seen out there that organizations really need to look carefully at to reconsider, what kind of message are they sending to the organization? Since remember, families want, as Marty was saying, they want open and honest and empathic communication after all harm events, independent of whether it's a known complication or what have you. They want to know what we know as it relates to that. And they're ready to accept the fact that care was okay, but they would just like to have that conversation and have people explain to them, what it is that happened. So if you go to the next slide, you'll see another policy where, again, the disclosure is not, as you can see at the top there, one of the overall statements is the policy does not apply when a known complication has occurred, which is troublesome because so many known complications may be caused by inappropriate care. And in this particular area as well, they provided this outline for disclosure, but you can see every one of them is triggered not by harm, but by error. And level 1 is, as you can see, error occurred, but an intervention prevented it. So sort of a near miss. Level 2, an error occurred and it reached the patient, but the patient wasn't harmed. Then level 3, an error occurred, it reached the patient, required an increased length of stay, all that sort of stuff. But again, all of these are triggered by error, not by harm. And again, a big interest that people have is is modifying their approach to this so it really addresses what the patients and families need and even what the caregivers want, which is a system that where systematically and in a principled way you're responding to patient harm. Next slide. So Marty and I were fortunate enough to work on a paper that was recently published this year in the Journal of Patient Safety and Risk Management. And this was in May in 2018. Kate can send out to you a reprint of this if folks are interested. But it really is our lessons learned from the first 200 hospitals we worked with around the country in the implementation of a CANDOR type program. And we got a lot of lessons learned that we want to share with you as we get into a little bit more towards the end, some things to consider about implementation. So the next slide. So these are some of the lessons learned about things that may exist that may make it, and absolutely, Michelle, I will make sure Kate gets that out to all of you. It's got a lot of really, really cool information in it. So here's what we found in these organizations as potential barriers to fully successful implementation. The first is you have to have board engagement or executive leadership support, without a doubt. If you only do this, as bullet point 2 says, as a risk management program, at least in Chicago, what we identified, you are pretty much guaranteed to fail. This will not be comprehensive, it won't be principled, and it won't be a systematic approach. It'll be a lot of people who are struggling in risk management or patient safety trying to meet some of these needs. And so you have to have executive leadership support. The other piece that's really important early on to think about is how you can get medical staff involvement, where you have some medical staff champions or some others, including your CMO, who really feel like they've been part of putting the process together. And if they do that, you're more likely to get them to trust the organization's approach, especially in these systems, as we can see there, where you may have a group of independent physicians. It's really important early on to get them engaged. And again, you'll know this by really doing this needs assessment in your organization. Next slide. The other piece is to recognize, as we say over and over again, that looking to see here. Can you go back one, Kate? I'm just looking to see. We may have skipped a couple slides. All right. At any rate, go forward again. The other piece that's important is that if you have one or more prominent executives who actively oppose the process, it is going to be difficult. So it's important early on that you really get a sense from all the key stakeholders of where they stand as it relates to moving forward with this. The other part that we really identified that was super important is this presence of other priorities. In 4 of our hospitals in Chicago, and you guys on the call here can imagine, 4 of our hospitals in Chicago were implementing for the first time their electronic medical record. They were launching Epic at the same time that we were looking at CANDOR implementation. And so there was no way that the attempt to put this sort of comprehensive safety program was going to get any traction at all in the context of that. But because we were doing this study, we went ahead with it and actually identified, wow, that's a source of failure. The next slide. The other thing that may be difficult is if there's not an appreciation for how comprehensive this approach is when it comes to, again, the Go Team concept, where you're going to respond quickly and you're going to have these sort of 3 simultaneous things happening, but all linked together. The other part, and this is the part, Marty, if you want to speak a little bit to, is this whole notion of the punitive or unprofessional culture and how much we try to learn in these focus groups, the comfort level people have, whether there's a feeling there are safe spaces and things like that. If you want to comment on that, Marty, because I think that's a critical piece.
Yeah, I would say that it really comes out in the interviews that, whether people feel, regardless of what your policy says, whether they're actually feeling that the culture takes care of them, and whether they feel comfortable stepping up and talking about unexpected harm. One of the things that, Tim, you'll probably get to this, but CANDOR implementation almost always increases, if it's done right, increases the number of reports that come out, because people feel like their culture is taking care of them, and then it's okay to report these things. So it does. It just really comes out through these interviews. Tim, if I could also just comment a little bit, the shift, I think, from the focus on error to the focus on harm, unexpected harm, is transformative, because error is a social judgment. No one likes to have on their record that they were involved in an error. If the shift goes to harm, which is natural because we often don't know whether there were errors until the investigation is done, it just opens up people. You could hear the sigh of relief as people talk about this, and especially if the organization, either as a matter of policy in its meetings with staff, but also in its meetings with patients and families, step up and take responsibility as an organization for the unexpected harm in a way that doesn't point the finger at the people in the organization. That's just really, really important.
Yeah, that's great, Marty. I mean, as we paraphrase sometimes, the goal after harm, as you say, is to really hug and love the patients and families and the care team through these events. Yeah. Independent of whether or not we even know yet or understand yet that errors or mistakes were made. The bottom one there, again, is it's important to be mindful of. You may have thought leaders who are sort of in agreement with moving forward with this, but as certain cases come up or what have you, they may sabotage some of your efforts to move it forward. So again, understanding whether you have saboteurs in the organization is a really critical piece to successful implementation. Next slide.
Jim, this is Marty again. If I could comment just a little bit too. Two of the authors on this paper were executives from a liability insurance company that were supportive of this, and that's supportive of implementation of CANDOR. And that's something that we saw in the Iowa workshop this summer. Your liability insurers were there, and were learning about this and curious about this. And that's really important to get physician buy-in, because as we all know, physicians listen to their liability carriers. So I think that's a real positive there. Also, I wanted to say in the role playing, really showing leadership stepping up and reinforcing that it's the organizational responsibility to have this comprehensive principled approach to harm. It's the organization's responsibility that drives the communication with patients early on, that doesn't blame the people in the organization for their involvement in these events. That came through in the role plays that we had this summer in a way that I thought was really, really powerful for those people in the room. I mean, you learn how to kind of just communicate that in a way that satisfies the expectations and needs of patients and families for the truth, and also takes care of the workforce.
Yeah, well said, Marty. And then as you can see on this slide, there are those who will say, hey, we're already doing it. But when you really do one of these gap analyses or needs assessment, you realize that there may be incomplete implementation of all the components, or that it may be very selective in terms of which of those situations when we do reach out to patients and families. And again, later on this slide, again, as you can see, leadership turnover is a really critical issue, in that you need to constantly be thinking about a succession plan, which is to say, if you lose a key nurse or nurse executive or a medical executive or a patient safety expert, always be thinking about, if you were to lose them, what's the succession plan? What are you pondering? Who are you preparing to step in the event of, again, of succession? Next slide. This slide is going to show some of the important data that we found, which is, I think, really important. When we've interviewed so I can tell you way less, actually it's probably way less than 5% of the 200 hospitals are collecting and actually analyzing data on harm events based on race, ethnicity, or preferred language, and even disclosure, communication after harm events. I can tell you, sadly, at the University of Illinois, when we really started looking at this data, we were unconsciously being much more selective about who we were reaching out to, and embarrassed by the fact that there were some racial disparities that we needed to be very intentional to overcome as it related to our communication. The other two things that are important is most organizations rely on a more formal EAP process to support caregivers. Even though particularly amongst the medical staff, they'd really like to have a more informal care for the caregiver process where there isn't something as formal related to, you know, them getting emotional first aid. Next slide. So what I want to get into now, and we'll go through these slides pretty quickly, next slide, are just some ideas around building a CANDOR implementation, sort of process. This list of 8 bullet points comes from CANDOR, probably the most referenced article in the world right now. I think there's many thousands of references to CANDOR's article on leading change, where when you really want to change the organization, these are some of the steps that are really important to not only changing it, but sustaining it, starting from that sense of urgency, building your team, developing the vision, the strategy, particularly the marketing strategy, how you plan to communicate this, empowering the team, and moving all the way forward doing that. One issue as it relates to that vision and strategy and marketing, different organizations have done different things to really make this paradigm shift real and sticky. For example, at Dignity Health in California, they call their Care for the Caregiver program We Care. It's all one word, capital W, capital C, We Care. And they have 40 hospitals, and the posters are up all over all these hospitals saying, if you need support, if you've had an event, we have a team available for you 24/7. At Banner Health, their Care for the Caregiver program is called Talk to Us. Again, it's a marketing strategy they put out for people to realize this isn't the quality safety project du jour. This is something that's become part of the DNA of the organization. Next slide. So different organizations have set this up differently, but boy, I'll tell you, in terms of creating a sense of urgency and getting people attention, selling the story is critical, and the power of the patient narrative. Where you combine that with the business case, you're really connecting the heart with the head. And Marty, do you want to share a little bit about that? Because you've been the nation's leader in the power of the patient story and patient and family engagement, and how valuable this can be.
Yeah, the stories are important. I mean, I think part of it is just shifting who talks to who about what. So when you bring patients and families into training, it demonstrates the wall of silence going down. And what comes out of it invariably, I mean, in all my experience, is that the empathy just grows. Patients and families hate litigation. They want truth. They want to trust their organization. I think the really exciting findings out of CANDOR is that they will trust their organization even after harm. And that just comes through by bringing them into the trainings that we do. They also, beyond their stories, they also have, contribute their own lessons learned. I mean, we see the patient journey from our point of view. They see it often in a way that includes factors that we miss. All the coordination of care stuff that families miss, the things that they see, the things that they kind of, have noticed that go from unit to unit in a hospital, or hospital to other settings. They contribute that knowledge as well. So it's just win-win in a number of ways. It's often very emotional. It's often kind of hard to listen to, but our evaluations in Iowa and elsewhere just show how much of a difference it makes. I think it also helps, this is sort of basic, but we all on the provider side have loved ones too. So that empathy kind of triggers the fact that we, probably have our own family members who've been hospitalized and have experienced things that weren't perfect, or at least we worry about it. And all that just kind of happens seamlessly when we bring them into these events.
Yeah, thanks, Marty. And Kate, thanks for sending that question out. We've already had several of the members of the audience comment about how powerful it was, which, again, this is one of the things that really, really, really are important. Marty, there's a question about anything that we have on PFACs that could be shared with them and prospects. So do you want to comment on that a little bit in your connection with Kate and the ability to kind of push out some of the really cool stuff you're familiar with?
Well, we have all sorts of tools on building PFACs, and we also just finished a project through the HIMSS that we've not published yet. CMS is still sitting on it, but it's just looking at the hospitals and the systems that have successfully implemented PFACs, working in quality and safety. And keys there, I can tell you, I can't share the document with you quite yet, but I can tell you it's connection to mission and vision that is really got a connectivity to the board. The organization's leadership has to know that the PFAC is there and doing work. It empowers the PFAC. It also embeds the PFAC as a resource for the entire hospital community. And then really doing some training for both PFAC members on your safety work, and that involves transparency about your data, and also preparing your staff to welcome them, and then also just innovating. Once you build your PFAC, just looking at the ways in which you can use it. And we've got some really great examples of that in this work that we just did, visiting hospitals all over the country. And for the first time, we're able to really show an impact on outcomes. We studied falls and readmissions and found really significant reductions in both when a PFAC sort of amplifies the work you're already doing in those issues. So it's great. We've got the tools to share with you now, and the data will be coming very, very soon.
Thanks, Marty. Yeah, Kate, so we'll get that to you, as we have it, after the webinar. So next slide. So as you think about building your CANDOR implementation team, this is part of doing your needs assessment, is how might you be ready to do it. You don't have to do it this way. This is just one example of how some hospitals have set up their CANDOR implementation, where somewhere in the organization you find that CANDOR sort of change team leader, and then again you have the components of the go team off to the left there, and then ultimately your claims, legal, your resolution team. But off to the left you sort of have the disclosure lead. I prefer to use the word communication lead, but this comes from the CANDOR toolkit. Then you have a lead for the peer support or care for the caregiver team, and then that event review lead. And that, again, the goal here is that all of these are hardwired and connected to each other as you move forward. Next slide. And at the end of the day, you do need to develop this shared vision and strategy, where the organization is going to want to share its mental model with all of these pieces of the organization to really understand what it is, and then develop a strategy that includes identifying the events that you plan to respond to in this comprehensive way. And then you also need to develop that measurement strategy. Next slide. And so one of the things that organizations do need to do is, we believe as well, is to focus on the harm events, and that you still need to look at your no harm, your near misses, and your unsafe conditions, and in constant quality improvement iterative process. But as we've been talking about this, that response that includes the early and ongoing communication usually involves harm. Next slide. And again, this next slide just sort of shows the overlap between the harm events and the ones that again, we believe patients and families want. They want all adverse harm events to be responded to, but it's important to know that some will be preventable, some will be non-preventable, and in that some small subset, some of these will involve negligent harm events, which are the ones that we believe need to be positioned for early resolution. Next slide. So one of the things that you're going to want to also think about is a measurement strategy. And I can tell you, and Kate will be sharing more with you on this, we have a large amount of funding to do what's called a metric project, which is to give organizations those things they can measure that measure the progress of their implementation and the success of their implementation. That includes things like what to measure, who are the best people to measure it, when is the best time to measure it, and how to measure it. You know, for example, how quickly are you responding to harm? You know, how often are you following up with patients and families, and how often do you need to follow up with your caregivers, all these things. And then obviously tracking how well are we improving in terms of preventing and reducing harm events. Next slide. The other piece is, once you decide on your strategy, is really think about how you're going to communicate this shared vision to all staff. And once again, we believe that using personal stories of caregivers who have received peer support, how they can talk to how important it is. A lot of times that may be members of the medical staff or nursing staff or pharmacy. But then also think about creating and disseminating your materials that reinforce your components of candor and kinds of, again, creating these kind of market materials. Next slide. Because at the end of the day, you do want to empower your candor team to act, so that there's this shared sense of purpose, and then train the staff so they have the desired skills and attitudes. That's a lot of what we did during the 4 workshops. A lot of wonderful videos have been created with that we'll be working with the Compass Hin on to make available in as nice a way as possible for organizations to do this ongoing learning. And then, of course, remove any of the obstacles to change you've identified during the gap analysis. Next slide. And so you really want to set goals so that you can build on the momentum, and particularly of any of these short-term wins, that you have up. And then recognize and reward people who do a lot of this sort of stuff. Let's see. So Marty, there's been a question asked about, I think what she's asking about is return on investment. Do you want to share a little bit with that? Because it is not at all just limited to claims and lawsuits. Do you want to share some of the other information? And we actually have a data sheet on this, Colleen, that we could share with you. Marty, you want to speak to that?
Sure. Well, an obvious one is just retention of your customers, of patients and families that choose to continue to get their care with your hospital because they trust you. That comes through loudly. I think the return on investment from your workforce, it feels like the organization is taking care of them in terms of longevity and staying. I mean, we've looked at hospitals that have better retention because of the way in which this is playing out. The other thing is, once you build the infrastructure for this, especially that 24/7 Go team that immediately responds, what we're finding are organizations who build that and the care for the caregiver piece can use it for a number of different purposes. So it's not just about unexpected harm in terms of patient care, but it's about other kinds of harm. We've seen hospitals trigger that when there has been, for example, an employee heart attack on the job that sets a trauma through the organization, or some other event like that. Losing a patient that was a beloved known patient, things like that. So once the infrastructure is there, you can use it for a number of things. Tim, there's a number of other kind of things that we're tracking. I mean, it's claims, it's reports. Reports go up. I mentioned that earlier. Honestly, sometimes it's competition. It's distinguishing yourselves from other organizations in your market. And I think it's also paying off for those of you that are involved in putting together systems, or hospitals that are coming into systems. That change adds stress, and implementing a program like this can actually address that, those stresses. The last thing I'll mention, Tim, and then pitch it back to you because I'm probably leaving some things out. but when you talk to the top marketing people in the organization, and they're really thinking about how to convey, for whatever reason it is, competition, just community, goodwill, why they deliver care, candor becomes a topic or an aspect of that that marketing people really have some affinity with. Let's put it that way. It just kind of says what a mission-oriented organization is. It walks the talk of your mission often.
Right.
I rambled there, Tim,
yeah.
but I hope that's
Yeah.
helpful.
Yeah. So again, we have a list of this, Kate, we can send out to you, but here's the buckets I would put these into where we have clear data. You are right. There is tons of data to show this improves your liability numbers, but more importantly, with increased reporting and increased event review, you reduce harm. We have seen a significant reduction in serious harm events in various organizations that, again, may not get a lot of claims. The other piece is, and we published this data to show that physicians who work in this kind of environment practice a lot less defensive medicine. That was an article that was published in Health Affairs, which has a huge ROI for organizations because there's less defensive medicine tests that are ordered. The other piece that Marty alluded to is staff engagement. We believe there is significantly less burnout in organizations that really hardwire this, and there's less turnover for both physicians as well as nurses. And the board is going to understand the huge financial ROI that it has associated with that. The other piece that you will see related to this, that we're seeing at least at the University of California, San Diego, is significant decrease or improvement in mental health and decrease in suicides, which is, again, a very important issue as it relates to trying to deal with burnout and a lot of the other issues there. So there's a whole lot of reasons why this kind of comprehensive approach is so important and why it's not just a risk management approach with that. So I want to leave room for some questions here, Kate. So I want to run through the other slides fairly quickly, again, to leave more room for questions. But so in addition to this, don't let up, model the skills is another really, really important piece. And this comes from the team steps that was also funded by ARC, just like Candor was. And I think this is an important piece. Next slide. You're going to want to, create and sustain this new culture as you begin to do this and develop your steps for stabilizing, reinforcing, and again, sustaining the change. You're going to, next slide. One of the other things that we think is critical is to do what we talked about today, which is get this gap analysis done. Look at your processes, your policies, your systems. The tools are available in the Candor Toolkit. And Kate, as you know, Marty and I are available for questions or queries that any of the organizations you want to move forward have, because we've worked with so many organizations. Maybe we can help you with that. Again, the next slide, this slide we included in here so you can refer back to it. These are just the kinds of groups, and you could probably go to the next slide as well. I think the other part will come up. That these are the kinds of groups that we conduct these facilitated conversations with. I can tell you that some of the most rewarding conversations we had included people like transporters, frontline IT people, people who work in the cafeteria and other places, because boy, they really do understand the culture of the organization. And then the next slide is just how you may want to create the report. One thing I'd be willing to offer, Kate, if folks would want it, is we actually have a de-identified report of an organization that is totally ready for implementation. And we also have a report from an organization that is absolutely, under no circumstances, ready to go forward, where you can really see it would be a waste of time and resources to try to implement it. We have both of those de-identified reports we're more than willing to share with your organizations. And finally, the last slide is some organizations have pondered this from an implementation standpoint, which is some have created a steering committee with these sort of 4 work groups. that involve, again, disclosure, or what people would say is communication, work group, the peer support, care for the caregiver group, the resolution, and then that discovery and learning, the one that we really think a lot of the ROI, which is your created learning environment, where you're able to improve from these events. And you do need a group of people to look at your policies to see if they're written in a way that really support this kind of comprehensive piece. And then the final piece is really, having the organization define what is going to trigger, their response for that. So, Kate, I'm going to open it up now. Any questions that the group has? Marty, do you have any other comments before we look and see what questions the group might have?
I think the only thing that I felt we didn't hit today, Tim, and this is, I think those of you who were in the workshop series this summer experienced it, but part of the ROI is just the confidence that people feel when they go through the training. We measure that, and people report feeling much more confident coming out of it, that they are better communicators, that they would know how to handle communication, both with patients and families, but also with staff that you're trying to take care of and engage in your RCA processes as a result of those. The skill building, it comes through in the evaluations and the data and in the way we measure.
Kate, the other thing I would say that we could probably, connect with some of your members with is, in a bunch of the systems that we're working with, and even some of the individual hospitals, we have identified project managers, and because many of them feel so passionate about this, they'd be more than willing to talk to any specific organization that may be getting ready to, to move forward with this. And I would just like to, open that up and say we'd be happy to kind of help make any kind of connection with folks that are interested.
That's great, Tim. That's an excellent offer. I think you'll probably have some folks take you up on that. I think this has been a great session. You all experienced kind of the enthusiasm and the excitement we had as a group as we progressed through the CANDOR workshop series this summer, and it's generated already a lot of movement, but this kind of gives us pause to think about the things conversations we need to have organizationally as we start to implement these practices, and some good resources to lean on, both that are just out there like the ART CANDOR Toolkit, and also that you can lean back on this team, certainly for help and additional resources and support when you start moving forward. If you do have any questions, I'm going to give you just a minute or two to type those into the chat, and we'll moderate those. Certainly, if you have any questions, we want to make sure we get those answered today. But as you do that, I'll just let you know a couple other offers that we'll be making and follow up from the workshop series is IMS has offered to host a webinar that I don't have a date and time for, but sounds like will be in the middle of November. It's just a webinar focused on the Iowa statute. And I know that this is a question that has come in, and I can let Tim and Marty kind of speak to this, but not all states have CANDOR law. And that's why you see sometimes CANDOR all capitalized, and then here in Iowa you see just the C capitalized, and then it is in italics, and that's because of our state statute for CANDOR. And so just sort of understanding what the Iowa law says, what its protections are, and what the unique process is that's specific to the state of Iowa. So I'll be sending out information on that webinar in the coming weeks. And also, we'll be including in this follow-up email from today's webinar, we're offering some follow-up phone calls with you. If your organization would like to take advantage of some of these offers Tim has put out today, we'd like to hear about those and begin to connect you with the next step or next layer of resources as you begin to implement. So having said that, Tim, it looks like there's a question or comment in the chat, and I'll let you take that.
Well, I see Marty has submitted something out there, some information about the PFACs. and a link to that.
Oh, excellent. Yeah, I see that.
So I see that in there. I don't see any other questions from the participants, but I appreciate the comments and the other leaning in that people had. But as you say, Kate, we're available to continue to help working and supporting, you all as you, as you move forward.
Yeah. Tim, one thing I might add is that on the question about the competing priorities, several of the clients that, that I've seen are finding a way to connect their CANDOR work to something that's already a priority in the organization. So it's building on something that's already there, whether it's just culture or, something really connected to mission or vision. We've had some really interesting conversations with usually the senior strategic people at the organization that about how they would do that, because you could only do, 1 or 2 or 3 major things at a time, as we've already covered.
Great.
Excellent.
Yeah, I love Sarah's comment. We miss you too, Sarah. You guys were just amazing to work with as a group. You were so inspirational. And I can tell you our patient advocates loved meeting all of you. Carol and Teresa and Jack Gentry and Stephen Coffey and Chrissy Malizio, all of them love the work that you're doing in Iowa and love meeting you all. It was super fantastic.
We are at the top of the hour, so with that, I think we'll conclude today's session. I want to thank Tim and Marty for joining us today and bringing this follow-up content. As I mentioned, I'll be in communication with you in the next week with a follow-up email that includes the slide deck today, from today, a recording for today's webinar, if you'd like to share that within your organization or to others. We'll also be including links to the PFAC resources, and other things that I've documented that you've asked for here today, and providing opportunities for a follow-up call. So I appreciate all your participation in today's webinar. Thanks for joining and have a great day.
All righty. Thanks, everybody.